Truly a great honor to be on the list of distinguished Retnitzer lecturers over the years. In 1970, I did an essay on cardiac rehabilitation when I was at York University, and most of the references were to one P.A. Retnitzer. I could hardly say the name at that time. In 1975, as a PhD student at U of T, I studied about 100 cardiac patients in a study funded by Peter Retnitzer as the principal investigator of the Ontario Exercise Heart Collaborative Study. So Peter was the absolute pioneer in cardiac rehabilitation. Then time passed. I ended up at Western. And at a meeting one afternoon in Dr. David Cunningham's office, Peter said, "I think we know everything we need to know. Cardiac rehabilitation through exercise is a great thing. I think the next thing we should study is exercise and aging." Peter was approaching 60 at that time, hence 30 years ago. Okay. I was about 38 and said, "Really, aging? All those old people?" Why was Peter suggesting that the next place to go was exercise and aging? About 10% of the population at that time were over age 65. Okay? Pretty soon, 20% of the population will be over age 65. And those little black bars are the numbers of people, or the proportion of people over 85, which will more than quadruple in the next bunch of years. All the baby boomers and an increase in life expectancy, not only a huge number, but a huge proportion. So 1 in every 5 persons will be retired old folks. Okay? So that was the concern. And the other part of the concern is up to about age 65, we cost the healthcare system about $3,000 per person. Once you reach age 65, that goes up to 5,000 or 6,000, and it goes up exponentially, such that when you're at about age 80, $12,000 per person. Okay? So an older adult costs 4 times as much as a young adult to the healthcare system. Is the healthcare system sustainable without Alberta oil? I come from Alberta, so. And you know, the governments aren't talking very much about this. Even though 30 years ago, Peter said this is going to be a problem, we still don't have enough long-term care, enough nursing home, and we haven't done enough to prevent age-related declines. So what happens when we get old? We get chronic diseases, arteries stiffen, we get high blood pressure, visceral fat mass. Our aerobic fitness goes down. Our maximal heart rate is reduced about a beat a year. Nerve conduction velocity is reduced. We slow down in our walking speed. We get pre-diabetes, and we lose bone mass, strength, and density, and head towards osteoporosis. Okay? We lose muscle mass, strength, and power, and even the speed at which the muscles contract. So these are all the problems of aging. Is physical activity a reasonable solution to treat our older population? Well, a lot of epidemiological research since the bus studies in London, England, of conductors versus bus drivers and who got the heart disease, and the active conductors who ran up and down the stairs didn't get the heart disease, the lazy bus drivers did get the heart disease. Many, many studies since then have proven that regular physical activity is preventative against all of those conditions: heart disease, stroke, hypertension, diabetes, osteoporosis, obesity, colon cancer, breast cancer, and now a couple of other cancers, probably anxiety and depression, and even now a big push on looking at the effects of physical activity on cognitive function. 2 great authors, Booth et al. In 2012, published an article that talked about exercise as a primary prevention of at least 35 chronic health conditions. And Saltine, who gave a Retnitzer lecture many years ago, in his article showed that exercise was a therapy for 26 different chronic conditions. Very convincing that exercise is darn good for a lot of health-related outcomes. So today I want to look at what kind of physical activity. What should you be doing? So I'll take you through some research studies that informed what we now have as the Physical Activity Guidelines for Older Adults, published in 2011. So I'll show you the evidence that tells you what activities should be done. We'll look at what happens to your cardiorespiratory fitness as you age, and how to maintain or increase your cardiorespiratory fitness, or how to train when you're older. What happens to your strength as you age, and can you increase your strength? Can you increase your muscle mass? And should we be doing flexibility training, maintaining flexibility of our joints? A number of studies underlining what kinds of activities should we do are so-called epidemiological studies. They take these 100 people, they find out all sorts of information about them, they wait 10 years, finds out who gets coronary heart disease, who gets all-cause, who dies. They look at those people compared to the ones that didn't get heart disease or didn't die, and try to sort out the factors that suggested that somebody was at greater risk of all-cause mortality. In all of these studies, they had some older groups in the study, and they looked at the fitness level of those people as one of their initial measures. And they looked at the unfit people as having a risk of 1. Compared to that risk of 1, people in the moderate fitness range, in around there, 50 percentile of fitness, had about a 60% risk. A 30 or 40% reduction in risk of heart disease or all-cause mortality in those that were of average compared to poor fitness level. And if you get up to the high fit level, more than a 60% reduction in risk. Some people thought all you had to do was get out of the low fit group. Others said, no, you got to get into the high fit group. But overall, these studies show a very linear dose response to change. The fitter you are, the lower your risk of heart disease or all-cause mortality. That's good. That means we don't just have to convince the sedentary slob to get more active. The middle people can get more active, and they'll live longer. Get more active. How do you change that cardiorespiratory fitness? Well, a few particular studies in the older adults looked at what physical activities helped you live longer. In men of mean age 68 followed for 12 years, those who walked 1 to 2 miles a day showed a 30% reduction in death rate compared to those who didn't walk a mile a day. Those who walked 2 to 8 miles a day showed a 50% reduction in death rate. So, from that study, I think I'd like to be walking 1 or 2 or maybe 3 miles a day. Men age 75 followed for 5 years and then another 5 years. On both occasions, they measured their activity. Those who were active on both occasions had an almost 50% reduction in risk of all-cause mortality. Some of them, at age 75, by age 80, at 75 they were sedentary, at age 80 they reported various activities, so they were now in the active group, and they had a 23% reduction in risk. The sort of, it's never too late to change this risk factor, to become active. These are from questionnaire studies, how active you are. Some people don't like them very much. So I threw up this study as well, where they measured your exact energy expenditure using a complicated doubly labeled water. And they found that those that had a greater energy expenditure of 287 kilocalories a day had a 32% lower risk. How much is 287 kilocalories a day, 2,000 kilocalories a week? If you went for a noon-hour run of 30 minutes, you might burn 300 kilocalories. So that's a mile or 2 miles every day of the week. So it agrees with these other studies. So that's really great. Walking can add minutes to your life. So when you're at age 85, you can go into the long-term care home and spend an initial $7,000 a month and spend the inheritance. That's not so good. I was intrigued by this graph many years ago. It's old data, but it makes the point. At age 70 to 74, so say you're 72 now, men will live 12 years longer, women will live 16 years longer. The white bar shows the portion of the life expectancy that will be in dependent living in the long-term care and the nursing home. And the yellow bar shows your active life expectancy. So the active life expectancy of both the men and women is only 8 years. Men will be in long-term care for 4 years, women for 8 years. Sorry, ladies, the amount longer you live in men than men you spend in long-term care. Men are smart, we just die. Okay. Does physical activity postpone the loss of function, the loss of independence, and disability? So this is what I wanted to address. How do we get rid of those? Live a nice long life and then die. We won't cost the healthcare system so much. Okay. How can we increase our active life expectancy? Remain independent till near the end. Well, once again, Peter came to the rescue. I was interested in this question, and Peter got funding to study older adults, and we studied 442 men and women aged 55 to 85. I think Lily tested every one of them on the treadmill. They came to the lab for 3 hours. We did medicals on them, physical activity histories, maximal oxygen uptake, which is the cardiorespiratory fitness measure, strength, anthropometry, socioeconomic status. We collected a lot of data. For my interest in how do you remain independent, 8 years later, we followed up and found out which of those people who were independent and ran on our treadmill 8 years ago were now living a dependent lifestyle, had lost their independence. And about 60 or 70 of them had lost their independence. If we look at VO2 max, which is the measure of cardiorespiratory fitness, and compare the lowest group with an odds ratio of 1, those of a moderate fitness level had an odds ratio of 0.7, a 30% reduction in the risk of becoming dependent if you were in a moderate fit level. If you were in the high fit level, oxygen uptakes of 20-25 milliliters per kilogram minute, your risk of becoming dependent was 60 or 70% reduced. So clearly the factors that kept you independent were age. If you started the study at age 75, the chance at 83 that you'd be dependent were higher. So we eliminated that one. If you had a prior disease, even though you could run on the treadmill, if you had a previous heart attack, if you had previous cancer, and your chance of becoming dependent was greater. The only other variable of all that stuff we measured was cardiorespiratory fitness. Okay. There was a 14% reduction in the risk of becoming dependent for each milliliter per kilogram minute you increased. That number will become important later. So that study showed that cardiorespiratory fitness in the older population prolongs active life, independent living, and decreases the percentage of time spent in a disabled state. So I was pretty pleased with that, but we still didn't know what physical activities you needed to do to get that cardiorespiratory fitness or that benefit of remaining independent. To do so, to establish what are called clinical guidelines, the same as they would in the medical profession, clinical guidelines for treating various diseases, we had to do a systematic review. That involves finding all the literature related to the topic of physical activity and aging and function and remaining independent. Go through all the literature searches using computer database. Then sit down with a consensus of experts who looked at all that literature to find out which physical activities should old people be doing. So I spent a couple of years going through that literature. It took a long time. And we wrote the systematic review related to physical activity and functional limitations in older adults. So we weren't interested in whether they died or not. We were interested in loss of function. These studies, plotted here, are prospective cohort studies, those epidemiological studies. We collect the data on all of you. We sit around and wait. And what we waited for was loss of function in terms of ability to do daily activities. Dressing yourself, vacuuming, cleaning, going to the bank, independent living. Okay. So what's the risk of losing your independence based on physical activity levels? So physical activity levels were reported in these papers. We had to judge what physical activity each of them, and compared to those who did the least physical activity, odds ratio 1. Those who did a moderate level of physical activity had about a 30 or 40% reduction in risk if we average all these studies together. Those who did the greatest physical activity had about 60% reduction in risk of losing those functions. Okay, these numbers are starting to make sense. It was the same for all-cause mortality. 30% reduction if you're in the middle group, 60% reduction if you're in the high group. All of these studies looked at functional limitations, but not at a lower level, at a little higher level. So they measured things like walking speed, or getting out of a chair, crossing a room, getting back into the chair, and how those related to your physical activity level, and how much you lost over time. So again, the physical activity level compared to those who were worse, kind of a linear change over time. Moderate fitness, 30 to 40% reduction in risk. High activity, 60% reduction in risk. Again, overall, a rather linear dose response. You can start being moderately active if you move out to Canmore and snowshoe once a week and ski once a week and play hockey once a week. You move into the high risk, and your chance of becoming dependent is 60% reduced. All of those studies recommended aerobic activities. Okay. The same as those previous physical activity studies where they talked about walking 1 or 2 miles a day, burning 2,000 kilocalories a week. They're all aerobic activities. So what should older adults be doing if they want to remain independent? The same as my study on cardiorespiratory fitness showed, aerobic. Cardiorespiratory fitness is a key. So becoming disabled or losing functional decline, a 50% risk of decline and limitation is possible. Higher vigorous activities, minimally moderate levels of physical activity were effective. Lower level light physical activities lack evidence and may be ineffective. That's probably the most important point you'll hear today. Light activities do not prevent all of those health outcomes. They do not prevent loss of function. Okay. Canada for a long time has been all over active living. Go and play with your grandchildren, do a little digging in the garden, this and that. It won't help you. Okay. Moderate, vigorous activities are what is needed. So all of those studies I cited don't show that light activities, even if you do 2,000 kilocalories of light activities, it won't fix you. Okay. So what types of physical activities? Walking frequently or daily for 60 minutes, 7 hours of walking a week, moderate and vigorous walking, walking for exercise, exercising moderate. That's how these studies described what you needed to be doing. We also reviewed in that systematic literature research, okay, so I don't want to get dementia or Alzheimer's, what physical activities prevent that cause of me becoming dependent. You find a lot of citations. It ended up that 34 are actually relating physical activity levels to cognitive function. So we had to review 34 studies. Cognitive function measures were highly variable. Some measured reaction time, some measured memory, many measured the executive functions. 2/3 of the studies showed a positive relationship. But I point out 1/3 did not show a relationship. Even if they measured all of these, and showed a relationship in 1/3 of those studies. Prospective studies, that's the long-term follow-up studies, showed evidence that if you had been active throughout life, the subsequent risk for dementia and Alzheimer's disease was reduced. Okay? But those studies don't say if you take up an exercise program and do it for the next 5 years, it'll reduce it. That's lifelong activity. Exercise training studies, the short-term studies, join an exercise program, be in it for a year, seem to have a positive effect on at least one cognitive function measure, probably the executive function measures. Okay. So overall, maybe. Okay. And that's a hot area of study right now, is what's the effect of physical activity on cognitive function. And for the purpose of my study, what's the dose of activity you need to preserve cognitive function? Is it light activities? Well, there's at least one study in the literature that shows hippocampus volume, the number of neuronal cells in your hippocampus, are related to cardiorespiratory fitness. So in old people, the loss of neurons is inversely related to their cardiorespiratory fitness. And at a UBC, a woman pursuing a lot of cognitive studies is suggesting that strength training may also be effective. But we really don't know for cognitive function yet how much its deterioration is prevented or what exercises to use. So integrating all of that information I've thrown at you. In terms of morbidity and mortality outcomes, the first bunch of slides, moderate or moderately vigorous exercise, about 180 minutes, burn 1,000 kilocalories a week, is what you should be doing. To postpone functional losses and to maintain or increase your cardiorespiratory fitness, moderate exercise. Active living people hate it when I use the word exercise. That'll scare off old people. Don't exercise, that's scary. 150 minutes a week, or you can do vigorous exercise of 90 minutes a week. But light activities did not prevent functional losses. Functional independence outcomes from the systematic review. Moderate, moderately vigorous, not light activities, 150 to 180 minutes a week. Cognitive outcomes, we're not sure. So, very convincing. Moderate to vigorous, 150 minutes a week. So then the consensus panel read this systematic review of all the literature we had assembled and came up with the physical activity guidelines for older adults. They're published at the Canadian Society for Exercise Physiology Physical Activity Guidelines website. It's not intended you can read them. It's planned exercise, so probably I was a little bit pushy in the committee and insisted that we use the word exercise as well as physical activity. Okay? Beyond physical activity accumulated in daily living. Okay? So the daily living activities that are rather light don't count towards your 1,000 kilocalories extra energy expenditure. Only the moderate and vigorous count. Okay? The benefits are in terms of health, preventing all those diseases, and function, living longer independently. Okay. And the key down here is moderate to vigorous intensity aerobic activity. To achieve health benefits and improve functional abilities, adults should accumulate 150 minutes of moderate to vigorous intensity aerobic physical activity in bouts of 10 minutes or more. The bouts of 10 minutes per more is to get the cardiorespiratory system up and running. Okay. So forget about taking the stairs. Forget about walking from the parking lot. Okay. You got to do moderate and vigorous activity for longer than 10 minutes to have any impact on your cardiorespiratory fitness. I'll get to these later. The guidelines also include strength exercises 2 times a week, and they suggest that more is better. So if you're doing 150 minutes and you want to go up to 300 minutes a week, you'll do even better. You'll get that 60% reduction instead of the 30% reduction. So what does that mean for older adults? What's moderate? What's vigorous? Moderate to moderately vigorous aerobic activities. The good thing for older adults is we've declined so much that walking now becomes a moderate activity. But not just walking. The British are very good at using brisk walking. So brisk walking, 3 miles an hour is sort of an average walking pace up to 4 miles an hour. And those in an older adult will elicit a stress of greater than 50% of their maximum level. Okay? That's what's needed to train the system, to get it to adapt. Okay? So your heart rate will be elevated, you'll be breathing faster, and if you don't want to monitor either of those things, you can say to yourself, how do I feel out of a scale of 10? Am I at a 6 or a 5 or a 4? You want to be at a 6. Okay? So what have I calculated here? I've gone through a bunch of calculations to show that moderate walking at 3 miles an hour for a 70-year-old involves about 55% of their VO2 max. 150 minutes a week would get them up to 700 to 800 calories of energy expenditure. How did I jump that far ahead? Whoa. No, I'm going back. There we go. Or if you want to get into the vigorous categories, you only have to do 90 minutes a week, like going to the gym and having a workout 3 times a week. For older people, going 4 miles an hour or very brisk walking or including uphill segments will get you up to about 65% of VO2 max, which is what an exercise physiologist would prescribe you do for exercise training programs. Your heart rate will be considerably elevated. I'll show you how much in a minute. You'll be breathless. You won't be able to sing the national anthem. And your exertion will be rated as 7 or 8 out of 10. Okay? Don't go by sweating responses. It depends on how hot it is and how much clothing you have on. Vigorous walking at 4 miles an hour will cost about 65% of your VO2 max. 150 minutes of a week will get you up around 800 kilocalories of energy expended. So you're close to the physical activity guidelines by 90 minutes of vigorous. The press only grabs on to exciting new stuff in the exercise literature. And so when we published these physical activity guidelines, they weren't very interested. They didn't pick up on the moderate and vigorous. They just said, oh, it's the same old stuff. You should do some physical activity. Then this article came out from Wen, All-Cause Mortality by Intensity of Activity Programs. And the press said, what Wen showed was all-cause mortality was reduced with a mere 14 minutes of exercise per day. Well, that doesn't get to 150 minutes a week, so the press criticized us for not being, or for saying people should do more than they needed to. Well, they only got a 10% reduction in all-cause mortality. To get up to the 30% reduction in all-cause mortality, you had to go out to 50 or 60 minutes. Exactly what we had said. But even more impressive, and the press didn't pick up on it at all until they called me and I said, you didn't look at the graph yet. This is the graph for moderate exercise. So if you do 40 minutes a day of moderate exercise, you'll get a 20% reduction in all-cause mortality. If you went vigorous, That same 40 minutes of vigorous exercise would get you a 40% reduction in all-cause mortality. This study just underlined the importance of intensity. Yeah. Moderate's fine. Go higher is even better. Go higher is even better. So it's not how much you do, it's the intensity of what you do. So what heart rate should you be at? Well, you've probably all seen the equation 220 minus age. Well, that's wrong. Okay. That would tell you at age 70, if you wanted to train at 75% of your heart rate, it would be 112 beats a minute. In our study of 442 people and in a meta-analysis at the University of Colorado, the true equation for older people is 208 minus 0.7 times the age. So at age 70, your heart rate max is probably closer to 160 beats a minute, 10 beats higher than you thought. And you should be training at 120 beats a minute, not 110 beats a minute. Okay. So if you've been following those guidelines, up it by 10 beats a minute next time out. Okay. Well, the trouble with heart rate monitoring is everybody's quite a bit different. So your maximum heart rate may not be 159, it may be 139, it may be 179. Okay. So how else can you monitor the intensity at which you're working? These are from American College of Sports Medicine. David Cunningham was involved in putting these together. The energy cost of walking is given by this equation. If I walk at 3 miles an hour, my energy cost will be about 12 milliliters of oxygen per kilogram minute. If I walk up a hill of 6% grade, the oxygen cost will go up to 20.1 milliliters per kilogram minute. So if your VO2 max is 25, that's too slow to get to 50% of your VO2 max. That may be too big a hill for you to go up. You'll really be working hard, 80% of your VO2 max. If you're really fit, there are equations for running and there are equations for jogging. So a little more on aerobic fitness. What happens to your aerobic fitness as you age, and can you train it? So aerobic fitness or aerobic power is the highest rate of utilization of oxygen during performance of large muscle group activities. So you have to be using 50% of your muscle mass to put enough stress on the oxygen uptake system to measure it. Women are inferior on VO2 max by about 15%, accounting for weight. That's primarily due to increased fat mass in women. There's about a 10% decline per decade, and this has been known for a long time and seems to be a darn good number. So a male may start at age 25 at 48 and a female at around 40. There's a large individual variation, so at any age range, 20 to 30% variation includes about 95% of the population. If you want to know what you're aiming for, 55 to 80 to participate in elite level 25-year-old sports. The highest male measured is 96 milliliters per kilogram minute, a cross-country skier, and the highest female 74. What's yours? Well, aging is the study of downwardly sloping lines. This is data from one of my doctoral students. In that study of 442 people, 10 years later, we got as many of them as we could back to the lab. This study shows 62 people who we got back. Their mean age had gone from 64 when we studied them first to now 74. We put them back on the treadmill, had them do the same test as they had done 10 years previously. The men, this is what happened over 10 years. Regardless of age group, almost all of them went down. 15% decline across the decade, 1.5% per year. The women, it wasn't as steep a gradient, but lots of going down. So the women just showed a 7% decline per decade in this study. By age 75, with the men declining faster than the women, by age 75, maybe the average is about 20 milliliters per kilogram minute. Maybe about 20 milliliters per kilogram minute. So men and women are about the same at age 75. 20 milliliters per kilogram minute. Remember we said walking at 3 miles an hour was 12 milliliters per kilogram minute. Walking up the hill was 20. That would be tough for these 70-year-olds. Okay. It appears that none of them were below 15. It appears that you need a VO2 max of 15 milliliters per kilogram minute to remain independent living in your own home. That's a pretty good guideline. If you go and get measured and find out you're at 16, you probably should be doing something about it. So cardiorespiratory fitness declines with age. We get down to about 20 milliliters per kilogram minute. Many daily activities require 12 to 15. If you're vacuuming the rug, like I have to do in our household daily, that would be about 75% of VO2 max for the 70-year-old. So that would be heavy intensity. That's the same intensity as a marathon runner at Boston would run. 75% of their VO2 max for a couple of hours. I'm very slow at vacuuming rugs. Required for independent living, 15 milliliters per kilogram minute, and 1/4 of the population at age 75 will be below that level. That's why fitness was so important to independence. 1/4 of the population is dropping below it. So a decline in cardiorespiratory fitness leads to loss of independence. Can we train it? Can we get a higher cardiorespiratory fitness? Well, when Peter suggested we should start studying older people, at the time, DeVries had studied them and found little improvement in fitness in older adults. Perhaps your ability to adapt is lost. After all, you're declining. Maybe you can't bump it back up. Okay. Or maybe it takes longer. Maybe they only did a 6-month training program and they needed to do a year or 2. Yeah. Bassing in England said, vague fears that too much exercise will precipitate injury, catastrophic exhaustion, or avert illness bedevil the situation, and have fostered disapproval of all but the mildest of exertion. That was the problem. Any studies done to that day were afraid they'd kill the old people, so they had done mild exertion. Okay. Doug Seals, the first Retnitzer lecturer in this series in 1984, published a study with 11 men that he studied in his lab. He was afraid he'd kill them, so he wanted them right in the lab where a doctor could watch them. Trained them on a treadmill for 6 months at rather mild exercise and found a modest improvement of 10 to 15%. The first study to show, hey, yeah, we can train them. Then in the second 6 months, he got aggressive and he trained them hard. Went from mild, moderate exercise to vigorous exercise on the treadmill, improved them another 20%. Okay. At that time, Peter Retnitzer and David Cunningham started the retirement research study. Okay. Unlike Seals, who had studied 11 men in his lab, this was a study of 100 men on the track at Western, and it was a year-long study with a control group. And after the year, the group that had been doing the training, which is a walk-jog training program around the track, had improved 10%. Okay. And a remarkable thing about that study, people say, oh, you'll never get old people to do this. 100 out of 104 who started the study completed the study of exercise training 3 times a week at like 7 in the morning. Okay. So yeah, maybe we can't convince everybody to train, but those said, yeah, I'll volunteer for that. That sounds cool. Actually adhered to the program. We can get older people to be active. And that retirement research group still exists. There's been some turnover since 1987. There have been lots of other studies. Yes, we can train older people. I will show the one of Juan Murias, my last doctoral student, that we published in 2010. Had a lot of interesting features to it. So we studied both men and women. I remember the day we were meeting and he was all ready to start. And I said, you know, we really should compare men and women. That doubled the study. And I said, you know, it's not going to be very good unless you compare what happened on the same training program to old as would happen in the young. Are they as adaptable? Can they adapt as quickly? So we doubled the study and studied the young people as well. We also measured them every 3 weeks. Okay, so we just didn't do a pre and post, and we measured lots of stuff. The stuff I'm going to show you is their VO2 max. So they trained 3 times a week for 45 minutes at a power output of 70% of their VO2 max. That's vigorous. First time in, they had difficulty doing it. They were allowed to take a short break. Then Juan would hit them and tell them to get going again. By the third exercise session, they were all able to do 45 minutes at 70% of their VO2 max. We also adjusted the training intensity every 3 weeks. So when we measured their VO2 max at 3 weeks, if it had gone up, we made them work harder for the next 3 weeks. Okay. Adherence to the program, like in the retirement research study, 94% attendance. Everybody attended 28 out of 30 sessions. Bill is here. He was in that study. He probably attended 31 out of 30 sessions. Change in maximal oxygen uptake in the men. The young guys improved 18%. The old guys improved 31%. And it's rather linear. Same amount of increase every 3 weeks. If you keep making it harder and harder, they keep adapting. They keep adapting. And we don't know when it'll stop because we stopped the study at 12 weeks. In the women, the young people, a 22% increase. The older women, a 17% increase. Again, pretty linear increase. It just kept increasing. Okay? So the men went from 28 to 36, the women from 24 to 28. Remember, for 1 milliliter per kilogram increase in VO2 max, you get a 14% reduction in your risk of becoming independent. This 4 milliliter increase would give a 50% reduction in the chance of these women becoming dependent. The men get like a 70% reduction in risk. So a 12-week training program reduces your risk by 50, 60, 70% that you'll become independent in the next 8 years, become dependent in the next 8 years. So what about that? Maybe we're not training them long enough. Start slow, be gradual. The attitude is start slow and progress slowly to prevent catastrophic exhaustion and injury. That Mura study shows no. We put them on at 70% of VO2 max on the cycle the first time they were in the room. Okay? And we increased it as fast as we could and drove them as much as we could. It's not necessary you make rapid gains in fitness if you work hard, and those rapid gains in fitness motivate you to keep going. You say, wow, look at what I'm doing. This is great. Your VO2 max might only increase 10, but we did another study where we put people on a treadmill at a speed and grade that we thought would tire them out in 10 minutes. They flew off the back of the treadmill at 7 minutes. Okay? Then we did an 8-week training program, put them on the treadmill at the same speed and grade, and they lasted 21 minutes. 3 times as long with a 10% increase in VO2 max. So now if you're doing household work, going for a brisk walk, you can do it 3 times as long and experience the same amount of fatigue after a short training program. And the rate of adaptation, as shown in the Murias study, every 3 weeks, and as shown in another study that we did where we measured them every week, the old people adapt at the same rate as the young people. Okay? So a certain number of percent increase for every 3 exercise sessions. Continued progression results in remarkable gains. So you don't have to be satisfied with a 10% increase. Once you get that, if you up the intensity, you'll get further increases. This was something John and I studied together for a long time, termed oxygen uptake kinetics. And the title, Why Are Adults So Slow? When we start exercise, it takes a longer time for adults to get their oxygen uptake up to the level that they need to do the task. So I learned this technique on my first sabbatical to measure oxygen uptake on a breath-by-breath basis. So every breath we're measuring how much oxygen they've taken in. Okay. And we get a nice little profile like that. So this person took about a minute or so to reach the steady state of oxygen uptake for what they were working at. I'm going to skip this one. So we measured this in older adults when I came back from California. And this is a young person. This is the rate at which their oxygen uptake increased, 26 seconds. So they had reached a steady state by a minute or so. These older guys, 65 seconds was their tau number. They didn't reach steady state till out here somewhere, 3 or 4 minutes. So to do the task, the oxygen uptake was delivered in the young person within a minute to meet the demand. In the old person, it took 4 minutes. What was the old person getting the energy from? From phosphocreatine and from lactic acid, from substances that end up producing fatigue. So the first 6 minutes in exercise, compare an old and a young person. The older person will say 6 minutes, wow, man, I'm tired. I think I better stop this. Okay? Because they've been slow to get the oxygen uptake. So we looked at this variable in Juan Murias' study of the 12-week training program. Old men started with a tau of 43 seconds. Within 3 weeks, it came down to 35 seconds, which was similar to what the young were before they started. Now the young further improved and got down to 20 seconds. The old ended up at around 32. But look at the change. It was done in 3 weeks. So within 3 weeks, you could get a faster rate of rise in oxygen uptake. You would be less fatigued at 3 or 4 minutes into exercise, and you'd say, oh yeah, I can continue this exercise for 20 minutes. Not a problem. In the women, very slow kinetics were improved remarkably within 3 weeks. We're just like the young people who were untrained, and by the end, down to 30 seconds. You can't get down to young person's trained values, but you can get to look like an untrained young person. What's happening? Why did this happen? My current PhD student wanted to know, well, what's changing. So this is old and young. The time constant for the old, with 3 exercise training sessions, 24 hours after that third exercise session, their time constant had got faster. Their oxygen uptake rose faster at the start of exercise. This variable tells us about what the muscle was doing, how much oxygen the muscle was extracting. And the muscle extraction in the old people paralleled the change in the time constant. So muscle extraction has accounted for the faster rate of rise of oxygen uptake. Why is muscle extraction higher? Because blood flow gets there faster. So the blood flow gets there, and the muscle can extract the oxygen out of it. A measure called flow-mediated dilation, where we put a blood pressure cuff on, block off the flow to the vessels, then release the blood pressure cuff and measure how fast the flow increases and how much the vessel dilates. Okay. Showed that the vessel dilated more quickly following 3 sessions of training. Okay. These other points are at 48, 72, and 28 hours. So it comes back to normal after 72 hours. Okay. But it's really this increase in blood flow, the vasculature have been a key. Okay. So the microvascular responses, or the function of the vessels, is probably related to getting oxygen uptake to the muscles faster. So a key to the exercise training is not so much your heart or maybe even your muscles, but distributing that blood flow to the muscles in the vessels. So slower kinetics result in more metabolic byproducts, leading to premature fatigue. With short-term aerobic training, you can increase the VO2 kinetics. Exercise in older adults improves vascular health, control mechanisms that are important for health and for function. A little bit about muscle physiology and how it declines with. Probably you detect a little difference in muscle mass across these two, and most of these slides are from Charles Rice's students. One loss of muscle mass is a loss of motor units. Okay? So we got a spinal cord neuron innervating a bunch of muscle fibers. That neuron in the spinal cord can die. Those muscle units are no longer innervated. Some of them can be picked up by a collateral from the existing motor unit, but some of them aren't. Okay? And we lose fast twitch motor units, so the muscle will contract more slowly. How many motor units do we lose? Different muscle groups studied in Charles's lab. Not so much in the slow contracting muscle, but the other muscles show at least a 30% loss of motor units. And it doesn't seem we can do much about that. Those spinal cord neurons seem to die. Okay. Long time ago, Lexall did autopsy studies and looked at muscle cross-sectional area versus age in people killed in car accidents, sudden death of various types, and showed about a 50% reduction across age in muscle mass. Nowadays, we don't have to kill people to measure their muscle mass. We can do other techniques. And here's one from Charles's lab that compares the muscle mass of a 22-year-old and a 95-year-old. Okay? Not only is the 95-year-old muscle greater than 50% loss in mass, but it's got these little colored things that are probably fat and non-muscle tissue within the muscle. So with the loss of muscle mass, you lose strength. Okay? Strength decreases between the 7th and 9th decade, maybe a little bit between young and old, and then quite dramatically to the very old. Probably more important than strength is power. To get out of the chair when you leave, it's going to require power. You won't get up very, very slowly. You'll do speed and strength. So the power in young or in old compared to young, and in very old. So in the very old, the power can be 30% of the young value. So just like cardiorespiratory fitness, although we didn't find it as an important variable in our study of 442 people, your strength level can go below some functional threshold, probably occurring earlier in females than in males because they're not as strong to start with and their decline is at about the same rate. So this study of older adults greater than 70 years, 26% could not climb a flight of stairs. How many people do you know move into a single floor dwelling because they're at risk of falling downstairs? 31% can't lift 10 pounds of grocery bag. They're going to become dependent. 36% couldn't walk several blocks. So we lose motor units, about 30%. The muscle gets smaller. There's a similar loss in men and women, 30 to 60% across the 50-year age span. The decline in strength and speed results in up to a 70% loss in power. And those functional losses may affect your walking speed, your ability to rise from a chair, and result in balance and falls. So maintain your strength. How can you do that? Resistance training. But I remember many years ago the McMaster group presenting a bicep curl where they measured intra-arterial blood pressure and it went to 400 millimeters mercury. It's supposed to be 120. It goes to 400 if I do that. Okay. So there was this little thing, maybe we'll blow a few blood vessels and maybe we'll blow them in the brain when we do strength training. Okay, so we better be really careful. And since we're losing muscle mass, is it even possible to synthesize protein when we're older? Is hypertrophy possible? And if you can improve the muscle, will you improve function? Another Retnitzer speaker was among the first to measure resistance training in older people, and with 12 weeks of fairly vigorous weightlifting, found hypertrophy of the muscle. Yes, the muscle could lay down new protein and increase in size. In a remarkable study, Fiataroni in Boston trained 90-year-olds in a long-term care using quadriceps exercise only, and she found a 9% increase in muscle mass and reported functional improvements such as being able to get rid of their walkers or their canes. And there are many other studies where they've used power training, they've used eccentric exercises. Nevertheless, even though you can increase the strength training, the studies about how much it improves your function say marginally. Okay. Some show an increase in gait speed, the number of chair stands you can do in a given time, and your walking endurance, but there are modest improvements. So the Canadian Physical Activity Guidelines say it's beneficial to add muscle and bone strengthening activities. Okay. They preserve bone mass and strength, they can prevent osteoporosis, and they increase metabolic activity, which may help with the problem of older people getting diabetes. How to go about it? Overload. And this is what we don't see in many older adult programs. We see weights, 2-pound weights being lifted 100 times, soup cans being recommended by all sorts of Canadian authorities. That won't do it. You won't increase your muscle mass. Some overload, lifting a weight that you're unaccustomed to lifting and lifting it until you can't lift it anymore. Okay. So you may curl 60 pounds, find you can do it 6 or 8 times. In the second set, you can only do it 5 times. That's the right amount of weight. Okay. Then progressive, as you get so you can lift it the second set, add more weight. Okay. So it's moderate to high intensity of effort, major muscle groups. 2 days a week seems satisfactory. You don't need to do it 3 or 5 days a week. And you can do different kinds. Recent studies, another Retnitzer speaker last year or so, suggested that indeed you can use higher reps and they will be effective. And so you could lift that weight 30 times if you want. But in that study, it still had to go to failure. Okay. So the key was lifting something that you can't lift anymore. And so he did 30 reps, and on the 30th one, he couldn't get it up anymore. I prefer to do 6 reps and can't get it up on the 6th. So the key is it has to be overload. You have to get to the point that it is really hard to do that last repetition. Resistance training doesn't improve aerobic fitness, even if done in a circuit training format. So strength training in the physical activity guidelines is an adjunct to cardiorespiratory fitness, not to replace it, as an adjunct. And as an adjunct, you get some of these extra benefits, but prioritize your cardiorespiratory fitness. Can you hang in for 10 more minutes? Okay, this looks like me when I was at York University on the football team. I wasn't real keen on doing these exercises, and I couldn't get my knee straight anyway. And I said, who cares? I don't think I need a straight knee to play football. These guys are doing the hurdler stretch, and they're doing it statically, and yet when they come to do the hurdles, they're going to throw that front leg up higher than it is there, and they're going to throw it up dynamically and fast. Bound to tear the muscle, I'm sure. This woman, I don't know what she's doing. This guy is not doing a stretching routine. That's just having a morning stretch. That's fine. He's not trying to increase his range of motion. He's not holding it for 30 seconds. You can do that. That's fine. So static stretching, muscles held in a long, elongated position for 12 to 60 seconds, are an effective method of increasing the range of motion in the joint. So if I did that daily, pretty soon I will be able to touch my toes. Okay. Physiotherapists use flexibility exercises. If you have a restricted range of motion, flexibility exercises can increase that range of motion. So if I have a frozen shoulder and can't get it above there, flexibility exercise, eventually I'll be raising it up more. The other reason to do flexibility exercises are to relieve muscle soreness and stiffness. You see people after their exercise program, a little bit of this, and they think the next day they won't be stiff. It enhances performance. So you see the athletes doing it because they're going to get better performance out of it. And most importantly, they're doing it prior to their jog. They're pushing against the wall, trying to knock the wall over, and to stretch their tendons to prevent injury. These three studies all say bullshit. Okay? So all the research done on flexibility, many studies show no relief of delayed muscle soreness. Okay? So if you stretch after exercise, you're still going to be sore if you're going to get sore from the exercises you've done that day. And you get soreness from things like downhill running from eccentric muscle contractions. But stretching won't relieve it or prevent it. Performance. So should athletes be stretching prior to an event? 125 studies, 270 performance measures of the acute effects of static stretching on performance. And the things aren't too hard to measure. How high can you jump? How fast can you run? How much weight can you lift? Okay. And to get rid of the brain, maximal voluntary contractions or electrically stimulated contractions. In those studies, 119 showed performance reductions. Reductions? Flexibility reduces performance? Yeah. 145 non-significant findings and 6 showed improved. So if you do flexibility exercises of a static nature prior to your performance, you'll reduce your performance as a hockey player or as an old guy. Okay. 3.7% a mean performance reduction. Okay. Yet all the guys I play hockey with, prior to going out, they all sit down and stretch their groins, and they're sitting there looking around. I'm skating around the ice as fast as I can, trying to get warmed up, trying to rise my oxygen uptake up to a reasonable level to play hockey. They're trying to stretch their groins. That's why I perform so much better than they do. In aesthetic sports, you have to do those. So that woman over there doing those silly flexibility exercises. But look at these aesthetic performances and ask how many of those people end up with bad backs. All of them. Dancers, gymnasts, too much flexibility exercise results in an imbalance in the joints and particularly back and hip problems. Dynamic stretching might be okay. But the dynamic stretching really are studies of warm-up. Okay? They're doing things you're going to do in the activity in a similar way to how you're going to do it in the activity. They're not trying to extend beyond your range of motion to get a new range of motion. So as I'm skating around, I drag a leg behind me a little bit to stretch that a little bit, but it's all dynamic, no static stretching. Okay? And those dynamic stretches, or a warm-up if you like, reduce the mean, or reveal the performance enhancement of 1.3%. Trivial magnitude, and in 37 of the 80 studies it was demonstrated. So, stretching, I don't know. So we decided to study it in old people. Yeah, it can be used in the rehab context. If you've lost range of motion, go to a physiotherapist. They'll recommend some stretching exercises. But most of the literature says there are no known health benefits to stretching. It doesn't prevent injury, doesn't relieve muscle soreness, doesn't improve performance. Yet for decades it's been considered an important aspect of fitness. What bothered me was I went to a lot of older adult fitness programs and watched them, and they were 80% flexibility exercises. My mom went to sit and be fit. She walked from the 6th floor down to the 2nd floor, sat on a chair, stretched her fingers in her neck and whatever else, walked back up to the 6th floor, back down the hall to her apartment. And that was her sit and be fit flexibility exercises. They're rampant in old age homes. Okay? What's the role of flexibility? Can it be improved in older adults? Well, in our large population, we measured the flexibility. This is for the shoulder joint. This is for the hip joint. Oh, sorry, this is for the shoulder joint men and women. This is for the hip joint men and women. Decline of 6 degrees per decade, somewhat accelerated beyond age 71. So apparently people have trouble with the shoulder joint, can't get it up there. So I guess when I'm 90, I'll be 18 degrees shorter than this. I'll be about there. I can still get the peanut butter off the top shelf. So I'm not worried about losing my flexibility. A systematic review of flexibility studies in older adults where they looked at functional outcomes with flexibility training of walking speed, timed up and go from a chair across the way and back, sitting to standing, and balance. 1,000 participants, males and females, age 74. One half showed some positive functional outcome. One half showed no improvements. 4 out of 6 randomized controlled trials. That's where they compared the flexibility group to a different exercise group. And no relationship with flexibility and functional outcomes. Okay. So why are we spending all this time doing flexibility exercise in older adult fitness programs? You can improve the range of motion. There's no transfer to functions of daily life or the ability to live independently. And so now the physical activity guidelines for older adults in Canada do not say anything about flexibility, and nor do the US, the UK, Canada, or the World Health Organization say anything about flexibility. Cardiorespiratory fitness, aerobic activities, strength activities, and some balance activities for older adults. But you can throw out the flexibility. Keep doing it if you want. It probably won't hurt you. But don't substitute a flexibility program for those other things that you could be spending your time on. Normal loss of range of motion is unlikely to impact on daily life or result in disability. And if you start again, you'll be back up in 12 weeks. So they're mirror images, and there isn't any what they used to call muscle memory. In other words, you don't improve faster the second time around. Muscle strength, a little different. You don't lose it as quickly, and you probably get it back more quickly. But yeah, so bed rest is a tough thing on old people. If you have to go to bed for a week for some flu or something, big decline in cardiorespiratory fitness, probably 10% with a week in bed. And if you don't get that back, you're down that 10% suddenly. Yeah.
What ideas do you have about retaining the old elderly in exercise?
So long-term care, whatever? Yeah, the older old. If you can get them walking, and if they can walk for longer than 10 minutes, then do something else, then do another 10-minute bout, then another 10-minute bout. If they're not capable of walking 10 minutes, one process that's been used in heart failure, for example, is to do moderate strength training of small muscle groups. Okay? So single leg bench until the legs get strong enough so that they can walk for 10 minutes progressively. So you attempt to increase their cardiorespiratory fitness. And once again, their fitness is below 15, so you don't have to do much. If they're walking, they'll be at 2/3 of that maximum. So if you can get them walking for 10 minutes continuously, That would be great.
Thanks for the very illuminating presentation. If a person reaches a level with resistance training, cardiovascular exercise, and flexibility, which you're beginning to know, but should one keep pushing oneself higher and higher and higher, or should one be satisfied with a maintenance level of cardiovascular resistance?
Nothing wrong with a maintenance level. Yeah. So I've moved out to Canmore and I snowshoe and play hockey and whatever. I've had to increase my cardiorespiratory fitness in the last year to keep up with these other 87-year-olds who are doing the same thing out there. So I've been working out hard for the last couple of years to try to keep up to these older guys. But that's because that's what I want to do. If you're happy with being able to walk 3 miles an hour, 30 minutes in the evening, that's fine. That'll keep you independent. Thank you. In that study, we did divide the group at 9 weeks. We were afraid to divide it initially because high-intensity interval training is really tough. So we decided we better get them trained before we do that. I'm not so worried about that anymore. We didn't kill anybody. So high-intensity training popularized recently by the McMaster group, Kabbalah. It started with 30 seconds all-out exercise, 4 minutes rest, 30 seconds all-out exercise, 4 minutes rest. Then to bring it into the population and for health benefits, that was kind of athlete training. They changed it to 1 minute on, 1 minute off. And that 1 minute on was kind of prescribed at about 100% of your VO2 max. And so very hard exercise for 1 minute, then off for 1 minute. Okay. That's been around since the 1960s. Kabbalah studies have been pushed really hard because in about 12 minutes, you can same effect as 45 minutes of 60% of VO2 max. So if we have these people do 1 minute on, 1 minute off, 1 minute on, 1 minute off for 30 minutes, they've essentially done 15 minutes of exercise, 1/3 the amount of exercise these poor suckers going for 45 minutes have done, and they get the same benefits. But they don't get better benefits. Okay. We tried it on our grad students. That 1 minute on, 1 minute off, yeah, only took them 15 minutes in the or 30 minutes in the lab to do 15 minutes of exercise, but they were really useless for about 3 weeks. Okay? It was really hard work, and they were tired afterwards. Okay. So my final answer on that is I think the interval training is great. If you want to do it, go ahead. You won't get much greater benefits than doing the endurance at a moderate to vigorous level. And in fact, we did one study where we showed that the benefits to the heart were actually less. So the heart didn't adapt with this 1 minute on, 1 minute off as well as it did with the endurance training. The muscle did adapt better.
I'm going to take one more question and then we'll call it. Go ahead, please.
I think there are other things that stretching can do. I mean, you feel that you get down and on the ground and play with your grandkids and not fall over and try to get up again. Squat. And I think those are worth $800 for me. I noticed, by the way, that men who are not as flexible as women are always very down on flexibility. So
That's true. Yeah. No, and in part, you may also be talking about muscle strength, about getting down and back up. Yeah. Okay. Well, I guess my final advice, if you want to do flexibility, go ahead.
Okay, on that note, I want to thank Don for accepting our invitation. It was great. It is great to see him again.